Okay, so let's start the meeting. Hola a todos. Hi, everybody. Vamos a dar inicio a la reunión de esta semana, hoy en el Authorship Conference con el Dr. Song. Vamos a hablar hoy de un artículo. Entonces, esto es un Authorship Conference, no es una presentación. Y entonces, well, go ahead, Dr. Song. You can go ahead and start.
Okay. Good evening, Dr. Manuel and Dr. Alfaro. As you know, today we are going to review an article written by a fellow at UTASCA in San Antonio entitled Safety and Efficacy of Image-Guided Adrenal Cryoablation at a Single Institution. I'd like to start this session by asking several questions to Dr. Manuel, Ceredon, and Dr. Alfaro. Dr. Alfaro, did you have time to read this article?
Yes, I did.
So what's your opinion overall and then specific, anything?
Let's say, I think the abstract, I think was okay.
Mm-hmm.
The number of words and maybe the topic to have a general idea.
Mm-hmm.
But then I found, for example, in the introduction, one of the, let's see, for example, the first, I'll say citation they made, this reference was from 1950. That was like a details. I said it
10
was,
years.
it's two, no, like 7 years. What, from 1960?
10 years.
Or 19, no, the first one, 1950.
2018.
This one. It says the first reference it from 1950, about 7 years. 7 years ago. So I don't know.
Yeah. This one, right?
No. Up. I'm so.
First reference?
Yes, the first reference.
Reference.
The
Okay.
Abrams.
Yes, and for
Abram, yeah.
yes, that's something that
1950.
kept my attention. Then in the introduction, the author didn't explain the procedure as said as done, which I found in another article. I just check it very fast, but the reference number 6, yes. But here in the introduction, the author never explained the procedure, how it is done.
Okay.
And I found in reference number 6, I went to the article. I didn't read all the article, but I just checked it very fast. And then I understood how was the procedure done, for example. Then the author repeats some information in the introduction, and then in the discussion, the same one. And then there was a lot of information in the introduction and materials. I think that should go in results. And it was like a mix of information from different sections. I mean, information that should go in materials was in results, and information from results was in materials and methods. So I was kind of confused which information should go where.
Okay.
Yeah, it was like a puzzle. I couldn't fix very well. Okay. And some reference didn't have the year. And I think in the discussion it talked a lot about kind of a complication. Okay. Hypertensive crisis, but didn't talk too much about the procedure or the benefits. I think.
Okay. So, Dr. Sofia Gamboa, what's your opinion?
Hello. I agree with Andrea about that it was like a mixed, everything was in every section. But first, yes, it was
difficult for you to understand.
Yes.
Okay.
But first, I mark in the abstract the purpose. I think it could be shorter because first it make like a little introduction that could be read, right? written in the introduction, but after the abstract. So it could start, we saw to evaluate the safety and just that. After that, in the introduction, when it talk about other studies and compare everything, maybe it should be in the discussion or results when he make a conclusion and compare what he found and the other studies. So maybe it could be delayed from the introduction.
Okay. What about the materials and methods?
What?
What about the materials and methods section, this section?
Here, I think it's too long.
Yeah, too long.
Yes, too long. It explained everything. Maybe it could be shorter. And here it was a mess for me because there was things about the discussion that they were here in materials and methods. So it wasn't clear for me what he wanted to say.
So how would you make it shorten? As you mentioned, the materials and methods sections is very long. How would you correct or revise to make it shorter?
Maybe not describe everything, just not write like items, but make it shorter and not explain everything.
Like what? Which part are you going to delete?
Yeah, I will.
Overall.
Maybe I think here it says the inclusion criteria, exclusion criteria, but then when explained about the complications and what they do when they have complications, the drugs that they use, maybe all of that, it could be shorter.
Okay. And then what about the results section?
The results.
Result. Yeah.
Here, I mark. I know it was short. It wasn't too long. I didn't mark anything about results. I think it was good, but what I marked, it was in discussion.
Discussion, okay.
Discussion was really, really long, and in the end of the discussion, they didn't write about the conclusion. They write about what they think, what the results, but they didn't make a conclusion, so they didn't say exactly what they expect and what the results they have. So it was like an open end.
Okay, so I mentioned that it's important to write the answer. Again, the introduction is a kind of a question, and the first paragraph of the discussion is the answer to the question, right? So actually, this is not the answer, right? How would you answer to this question? And then again, what was the question for this manuscript, and what was the answer?
Can I ask, you said in the introduction or in the purpose of the abstract?
My question is
in the discussion. Sorry,
here
the introduction.
You do better to describe the answer, right?
Yeah.
So again, what was the question for this manuscript, and what would be the answer? So regarding the first paragraph, Dr. Celedon, what's your opinion?
In the purpose of in the introduction, they actually include that we sought to evaluate the safety and efficacy of adrenal cryoablation in patients treated locally for primary and metastatic disease of the adrenals. I think that's the purpose.
Okay.
So that's the question, I think. And in the discussion, well, I wrote this. Our study reports a 2-year local control progression-free survival and overall survival rates of 80%, 39%, and 77%. And I add this, supporting that percutaneous adrenal cryoablation provides a safe and effective alternative to surgical resection for local control of malignancy. I added that. That would have been my first paragraph in the discussion.
Okay, that's good. And then again, Dr. Gamboa, what's your opinion? You mentioned that there is no conclusion section. How would you revise the conclusion? One paragraph for conclusion.
I will write. I'm looking for it.
Okay, take your time.
When it said the result that they have with cryoablation, that would be the good conclusion, I think.
Okay. And any other comment or questions regarding this manuscript?
I have one. Okay, I also found the same thing as Andrea and Sophia. They had big mistakes in the materials and methods, particularly for me, was they included a lot of results there. That was one problem. A little bit too long, the introduction. The discussion was a little bit long, but it was hard for me to know exactly what were the main exact points that they were evaluating, because they talk about hypertensive crisis, and I don't think they talked about it a lot in the materials and methods very much. They mentioned something, but they don't talk about that was something that they were going to analyze. So they didn't. I don't know. So I was a little bit lost. In the end they talk about I don't know. They were. I have several things, but I imagine we're going to see it during during our discussion. But the thing was, there were several mistakes like that, and there was one mistake that I felt kept on coming up. In the very start, they say that the purpose or what they wanted to see in this article was to evaluate. It said here in the patients that were that the intention was local control. That's what they said. That they said the patients that were evaluated for local control, that was like the purpose, what they were looking for in the study. But during the evaluation, they mentioned the 36 patients that were included in the procedures, all of them. And they would go back to the 36 patients, and they would like go forward and talk about the 30 patients and the local control. And then they would go back to the 36 patients, and they say, oh yeah, and we had this malignancies in the 36 patients. We had these complications in the 36 patients. But I was like, wait a minute, they want to talk about just the procedure and about all the patients, or they want to talk about the patients that had local control, because they even mentioned that they exclude certain patients. So I have my doubts about, but that could be just my problem. I didn't understand.
Yeah, that's good point. Yeah, okay. And then I cannot share. I want to share another material.
Yes, sir. Right
there. And also, well, I agree.
Just a minute. Dr. Sheridan, you have to allow me to share. I cannot share.
Yes, sir. I'm doing that. Yeah, you can share now.
Okay, please go. Yeah, please go on, Andrea.
Okay, no, Dad. I also got confused with these numbers that Dr. Celedon just mentioned, and also yes, I mean hypertensive crisis took like the protagonism in some way. And then in the discussion, they said that local progression in ablations have been shown to be related with treated lesion size, but in the results, they don't talk about this, about bigger sizes. I mean, worst prognosis.
Yeah, I also they just put that in at the end, and they don't mention it during the entire article, and at the very end I also noted that.
Yes, and they say we demonstrated in this study, but I didn't find it before.
I am very happy to know that all of you are very excellent. So first I'd like to show my revision, and then before I show you my revision, I'd like to ask a question to Dr. Alfaro and Dr. Gamboa. do you want me to send this revision to you or to meeting attendees? Because this is the third time for authorship meeting, right? So the last 2 times I forgot to send it after the meeting, but I think this is a wonderful manuscript for beginners because there are many things we can improve. That's why I like this manuscript and decided to include this manuscript. So if you want, I will send this revision to you. Do you want to meet Dr. Alfaro?
Yes, I will, because we are starting, it's easier to find bigger mistakes. Okay. Because we don't have already, say, the expertise to detect small mistakes, but when they are huge, it's easier for us. So I think it's good to start.
Dr. Gamboa, also you want it, right?
Yes, I would like, because I mark mistakes that I thought, but now that we are talking about it, so I can compare and make it better.
I will send it to meeting attendees immediately after this meeting. Professor Lopera is on the line. Dr. Lopera, thank you for coming. Do you have anything to talk about?
Not really.
Okay. I will show you my revision. So overall, fortunately, all of you mentioned everything. So I want to discuss some important and also some redundant part. First, it would be helpful to clearly define the purpose of this study in introduction. So this is very important. And then describe the newness, originality in discussion. So again, the question at the introduction section and answer at the first paragraph of discussion. And what's the difference between this study and the other manuscript? As Dr. Alfaro mentioned, number 6, reference 6 is very interesting. I read it through also, 6, 14, 16, 19, and also I added several references to compare. So first of all, they have to know the difference between their result and this references result. Second, try to keep the flow from the beginning to the end. This is a common mistake. Also, writing manuscript, focusing on the questions and answers, and omit sentences which are not directly related with your observations and results, as Dr. Gamboa mentioned. And the third, it would be better and legible if the too long materials and methods could be divided into a few parts with relevant subtitles. I will show you what I...
Oh yeah, I was going to ask about the subtitles, because something else I did is I took a magazine, from endoscopy, and I saw that they have a lot of subtitles, and it's a lot easier to learn and to understand every part from materials and methods.
Okay, I will show you what I did for this one. Also, I changed the title a little bit because, as I mentioned, the manuscript is the summary of the text. And also the title is the summary of the abstract. So by reading the title, you can understand the abstract. So this is okay, just the safety and the efficacy of image-guided adrenal cryoablation as a single institution. But I cannot understand exactly what they did. And then I changed like this. Clinical efficacy and adverse event profile of CT-guided adrenal cryoablation at a single institution, a little bit changed. And then I like this one better. Clinical efficacy and adverse event profile of CT-guided adrenal cryoablation in patients with a solitary adrenal or well-controlled oligometastatic disease with intended for local cure. So this part can understand the abstract, right? So when you write the title of the paper, as I mentioned, is a gate of the manuscript. That's why it's important to give a right name to the title. So from beginning to end, please try to give a best title to your manuscript, because
so sorry, please finish.
Okay, so next time, 2 weeks from now, we are going to review an article written by Dr. Ceredon. So this is the last time for us to review an article. So that's why it's important to review what I have taught you. And then regarding the abstract, the total number of words in the abstract is 254. According to the rules, it should be less than 250. So I revised it like 188. So proposed section is too long. As I mentioned before, it's a good idea to just paste of the proposed section in the introduction section. So paste and copy and paste is okay. Copy and paste regarding the abstract, because abstract is just a summary of the text. It's okay to just copy and paste. So I made it shorter, like to evaluate, like exactly like a title. Materials and method. It was confusing. That's why I omitted all part and just I wanted to focus on 30 patients. 36 patients is a kind of a safety evaluation, but it's better to understand the efficacy. That's why I made it shorter. The results section is okay, but I added the average tumor size was like this. And then conclusion section, it is okay, but it should be the answer to the question. That's why I added the major adverse event rate for all procedures was 5%, and HC was detected in 24% of sessions with no immediate or long-term sequelae. Also, this is their purpose. Introduction section, it was too long, but it is okay. But I just revised it like this. Dr. Gamboa, can you read this one for us?
Yes.
Yeah.
The introduction, everything?
This one. No, this one. I just revised the introduction paragraphs.
It has been reported that patients with adrenal solitary metastatic disease or well-controlled oligometastasis may benefit from image-guided percutaneous radiofrequency ablation, microwave ablation, or cryoablation. Their local control and overall survival rates were comparable to those of surgical adrenalectomy combined with systemic therapy. Additionally, the option for surgical adrenalectomy is limited in some patients due to patient preference, comorbidities, or advanced age. In comparison with the radiofrequency ablation or microwave ablation, cryoablation has advantages because of its direct intraprocedural visualization of the low-density ice ball representing the ablation zone, which allows a higher probability of technical success while limiting the risk of collateral damage to nearby non-target organs. To our knowledge, however, there has been only a few studies on the feasibility and safety of adrenal cryoablation. In addition, there have been limited longitudinal follow-up time and adverse event profiles such as adrenal insufficiency and hypertensive crisis. Furthermore, there has been no study on the long-term sequelae of a hypertensive crisis. Therefore, the purpose of this retrospective study was to evaluate the clinical efficacy of adrenal cryoablation and its adverse event profile in patients with solitary adrenal or well-controlled oligometastatic disease with intent for local cure.
So do you think this is better? But what's your opinion about my revision?
I think it's more clear compared with all the what was written in the paper.
So as I mentioned, include.
Can I mention my review? Because
yeah, please.
I have two things. I really doubt about. Can I share my screen a moment, Doctor?
Sure.
So
yeah,
like I did this. I also shortened it very much, but I maintained a lot of what they had included.
Can you make it larger?
I made it very short. I made it a lot shorter.
No, I mean the magnification larger.
Oh okay.
Right. There is a 120% is better.
Okay. Oh boy. Like that?
Yeah, much better. Okay, good.
Okay.
Go on.
Okay. I want to ask about this, about when you're reviewing an article that somebody else has written. I don't like to step on the other person's writing or too much. I think that you have to let them in some way have ownership of the article. So I don't, like, for example, you rewrote a lot of it, not completely all of it, but definitely you added a lot of clarity to it and a lot of concepts that were missing. For example, they never mentioned about the lack of complication profiles or the long-term sequela of, they mentioned that during the whole article, but they don't include it in the introduction. They don't talk about it. So I think you definitely did it much clearer. But but you do rewrite a lot of it. So do you think it's better to just intervene and say, no, this is not correct, you have to change it like this, or maybe try to grab pieces of what they said and include it? Of course, when I see it yours, I completely know that my modification is not correct, because you definitely added all the missing pieces that they had not included. But I tried to take out what I didn't think that was that important, and tried to make the small introduction as small as I could and as to the point. So what do you think it's better to just dig in and rewrite it as much as you can, or make it as clear?
Well, actually there is no right answer, because introduction is okay. His introduction was okay, but I'm concerned about the length of introduction. If it's too long, the readers will lose their interest, because the long, right?
But I think it was just that it was long, Dr. Song. It wasn't just long.
And another one is that it's not good idea to describe the like a text, because you'd better to omit the everybody knows. For example, the preference of adrenal metastasis, and also it's not good idea to describe currently the possibility of surgery, comparing the surgery and also the interventional procedures. Everybody knows, so it's different. For example, you can think about a flask, right? Flask is the proximal part of the flask is broad. So he started from the metastasis. Everybody knows the first section, right? That's why I want to omit the first section. That's why it will be different from author to author, where to start from the proximal part of a flask. But I started from the middle part. You can understand what I mean?
Yeah, but for example, I didn't want to intervene here, because if that's what the author wants to talk about more, then I sort of I would have respected that. But at the same time, I took out a lot. For example, you included the whole discussion of radio frequency and microwave and cryoablation.
Why did I? Because you have to check the purpose of this manuscript first. That was a cryoablation, right?
Yeah.
That's why I started from this part, the second part. But it's okay to include the first part. Of course, why not?
Okay.
So there is no
right
answer.
No right answer. Okay. That's okay.
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 And then can I share my
Yes.
manuscript here? So anyway, this is one way of reviewing. So when it is well written, and I usually just check, I don't like to revise it, rewrote it, because rewrite it, because it's time consuming and hard. So when you want to rewrite the introduction section, you have to read all the references. Otherwise, it's impossible to rewrite it. And then regarding the materials and method, here, it would be better and legible if I mentioned this one and overall comment. So I made a subtitle like a patient population, cryoablation procedures, and adverse event, and follow-up, definition of outcome, statistical analysis. This is much better to understand, right? Patient.
Yeah.
And I just omitted this one regarding the safety evaluation, because it is very, very confusing to understand this one. Right. And then also,
I changed that a lot, Dr. Song. I changed that very much, but at the same time, I did omit it because I don't know this much about this topic to tell, like, for example, to tell them that is not important. For example, if they're including it, maybe it's because it's important for them.
Okay.
I don't see it. I don't see why it's so important. But if they think it's important, I think it's hard for me to just take it out. Maybe if you know a lot about the subject, it's easier to revise it and to say, no, this is not important. Take it out. I think that's part
sure.
of it. Yeah.
So when I revised one manuscript again, I have to know everything, because I have never been involved in cryoablation. That's why for the first time it was difficult for me to understand the whole part. So I read it more than 10 times, and I read all the references. That's why that was my role for authorship meeting. And then after the meeting and during the meeting, of course, I can ask the authors, what's your opinion? If they agree, they can accept my revision. If they don't agree, it's okay. And also, this is just my opinion. And also, more than 10 people joined the authorship meeting from Itasca. They gave their own ideas using track change function. That's why the first author can decide which one I can accept, which one I cannot. But I still remember the fellow emailed me saying that, oh, thank you so much. I will accept 100% of yours, but I have several questions. I still keep the corresponding emails. That's why there should be bi-directional communication regarding the authorship meeting before and after. Okay? Make sense?
Yes, Dr. Song. I have one question here.
I think if okay.
No, go ahead, Andrea. Go ahead.
No, that I think if there's good communication, the other doesn't feel that's an irrespect or something like that. They're just talking about it.
Yeah, sure. So if they don't respect my revision, it's okay not to accept my revision, but generally speaking, over 90% of them accept whole my revision, because I know about their background more than they do, because I read all the manuscript and also references, and also I added 7 references published recently. That's why I was able to compare their result and the previous report. That's why the authorship meeting is important, but it's okay. Sometimes it's dangerous. If you read the manuscript less than 5 times, it's impossible to give this kind of revision. Okay.
I have one question. So, do you think during the authorship conference, it's always you're normally like at UTASCA, you would do you would include like you would let people share their own revisions during the meeting? Is that what you would do too?
Yes, or like today, exactly like today.
So,
you shared your revision, right?
yeah, but
Also,
so mainly it's everybody watching your revision, and you can allow some people, if they have any points that they would like to share, to show theirs. Is that what you recommend?
oh, it's better to share their revision. But before I give my revision, like today, I didn't give my opinion, just listen to their opinion and how much they agreed with my revision. And then I didn't review all my revisions. I just review the part they didn't mention about. So this authorship meeting in your hospital is a little bit different from the UTASCA, because in UTASCA, the meeting attendees were very, very cooperative and proactive. Everybody gave their revisions before or after the meeting. That's why I used half of time for discussion and less than half or 20% for giving my revision. Okay? So discussion is more important, actually.
So you would ask people to send the revision to the author before the meeting?
No, after meeting. But some people after the meeting, but some people send it to me in advance, not to the first author. And some people send it to the first author.
Okay.
Yeah, but it's better to send it after the meeting because we can discuss each other. And then it's a good idea to listen to the meeting attendees next time when I review your manuscript. Probably I will do the same thing as I did in UTASCA, because at the time I revised their manuscript, but this is for lecture today, right? That's why I gave you my revision in detail, but next time it's not lecture, it's for revision. So revision for the manuscript written by your group is different from this authorship meeting. This is for combination of lecture and revision. Okay, understand?
Yes, it's just I'm thinking about the possibility of having the authorship conference, like leading an authorship conference. Mm-hmm. So we've actually never been in an authorship conference because, as you mentioned, we've been in in an authorship conference / presentation. So it's a little bit different. So yeah, I would like to be in an authorship conference. So maybe the one with my manuscript will be more like a
authorship conference. So to be honest, it is difficult to say this is an authorship conference. That's why I really want you to write your own materials. So this is a combination, again, lecture and the authorship conference.
Perfect.
Okay.
Yep.
And also, this is a past one, right? But it's not a good idea to review the past one. I'd like to review an article that you are going to submit to the journal. Okay. So here I corrected this long sentence into short one. I just mentioned that it will be better to delete the above 2 paragraphs and table 1. I wanted to omit the table 1. Instead, you can describe the following sentence here, like a total of 36 patients were treated with percutaneous image-guided adrenal cryoablation, and 6 of them were excluded from data analysis because of this one, and that one. So this is short, but also it's okay to omit the whole things if you want.
I also omitted that one, Dr. Song, but the thing is, see, this is an example of the part I was saying that they confuse. And I think it has to do with the purpose of the study, because the way you reviewed the purpose, you make room for these patients that were that had received ablation, but that were not that the purpose was not for local control. You open room for them. You just basically say, we want to see the complication profile. We want to see everything about all these patients. But because in the initial purpose, they only talk about, or they say that they want to talk about the local control patients, then for me, when they talk about all the histological malignancies of all the first group, I didn't think it made a lot of sense. They just said that they were excluding 6 patients. So why would they talk about the malignancies of all the 36 patients when they basically eliminated 6 of the patients? So I left the next paragraph where it says of the remaining 30 patients with 34 tumors. See, I left that part because the first part for me didn't make sense if you basically were eliminating 6 of these patients. But the way you rewrote it, now it makes sense. Now they can keep all this information. Yeah.
So when you write a manuscript, it's better to have one strong purpose, not many purposes. That's why if they want to write a paper on safety, probably you can make another manuscript. That's why it's better to focus on one thing. That's why I wanted to remove the safety issue. But anyway,
I was also confused in this part because I understood that they had like 2 different exclusion criteria or inclusion criteria to analyze the 2 variables. So I was like, is it allowed? Can you do this? Like, I'm gonna take 20 patients for this and 30 for this, but they belong to the same population. Yeah, I was also confused. It's okay to do it or not.
Okay, besides, there is no big difference between the safety issue and the efficacy issue. That's why efficacy issue is more important.
Okay.
Okay, and then also, this is minor, but also I'll review the one, for example, and the percentage is wrong. So when usually the first author, even though he read this manuscript many times, they could not find the difference because they made the analysis many times, sometimes 30 patients, sometimes 34 patients, and sometimes add more. That's why there is some typos and also mistakes. That's why I made this one. As I'm going to send my revision to you, probably I can skip the minor ones, okay? Also, I asked him to remove the 6 patient. Please exclude the 6 patient with procedure safety ablation. And then this also minor one. And also, this is important. For example, the technical technique has been fully described elsewhere, but there was no reference numbers. It's obligatory to add reference numbers when you want to describe. It was described the previous or something like that. Also, I asked him to describe. It seems to be necessary to briefly describe cryoablation technique used in this study, such as the size of cryoablation probes, how to insert them into the tumors, how long the freezing and thawing time did last. Because you have to he has to describe the difference between cryoablation and radio frequency ablation, which is commonly used. That's why it's better to describe the technique itself in detail, because their technique is different from the others by omitting the unnecessary things. Also, the subtitle was Adverse Event and Follow-up. Also, when you want to describe this one, there should be some reference numbers. Also, some part of materials and method from here to the definition of outcomes would be more appropriate in the result. So sometimes it is confusing because some part regarding the materials and method, you should move to the materials and method. And regarding the result, means what you have found is a result. It should go to the result section. What you have done should go to the materials and method section. That's why I gave this comment. Also, I omitted this one. Definition outcome, it was okay. And the statistical analysis, it was good. So I didn't correct much of it. And regarding the results, again, some part of the result would be more appropriate in materials and method. You can solve the problem by either deleting redundant description like origin of the primary cancer, or moving those parts to materials method. Also, this one.
I made an observation. I wanted to ask your opinion. This institutional review board approval, blah, 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 they mentioned it at the beginning of the materials and methods. Is it not, doesn't it look nicer, or isn't it better to put it at the end of the materials and methods section?
Usually it goes first. It's better. It's the trend. First. Yeah.
Oh, I see at the end. Okay, that's it.
But it's okay to describe it at the end, but it's better to describe in the beginning. Okay. And also I asked him, this is also, I was very interested in this one, like 50% of these patients had solitary adrenal metastatic disease, and 50% had well-controlled oligometastatic disease. So if there is any statistical difference between two groups, it will be interesting to add the result. Also, it seems to be interesting to compare the result between 23 patients with post-ablation systemic therapy and 11 patients with no post-ablation systemic therapy. But because of the small numbers, if there is no statistical significance, it will be okay. Also, I'll come back this one again regarding the figures. I'll move to the discussion section. As I like this style because I'll read this one. This is the answer to the question. We know the question, right? So the answer is, this retrospective study reveals the technical success rate was 100%. The primary technical efficacy was 71%, and the secondary technical technique efficacy was 74%. Larger lesion size correlated with increased risk of developing local disease progression. This is only one issue that's significantly important. That's why it's better to add this one in the regarding the size of the tumor. And the 2-year local control rate, because he mentioned that longitudinal follow-up is important, because the previous authors described the 1-year, 3-year, and the 4-year rate, not 2 years. But the surgeon, they described the 2 years. That's why he wanted to make a 2-year local control rate and progression-free survival rate, which is interesting. So this is a second answer. Regarding the third answer, the major adverse event rate for all procedures was 5%, and the HC was detected in 24% of sessions, and there were no immediately and long-term sequelae because nobody has described the HC, the long-term sequelae. That's why this is also something new. And three issues are okay, but if we can find another one, if you find any significant difference statistically in results between the 15 patients with a solitary and oligometric, it will be interesting. So at first, this is the first paragraph. At the second paragraph, he can compare his result with the previous report, like a 2-year local or something like that. That is second paragraph. And this part can be the second paragraph. And the third part, you can emphasize the difference. This is important, and potential advantage of adrenal cryoablation in comparison with adrenal RFA or microwave ablation. This is important. Also, many authors described their experience with radiofrequency ablation, but cryoablation has their own advantages. That's why they have to clearly define the difference between cryoablation and RF ablation, microablation. And also, I added many articles regarding the RF ablations. And the fourth paragraph, you can compare your result or observation in the adverse event, like HC, with those of other authors, because also this is something new. This part also. Finally, as Dr. Gamboa mentioned, I added one paragraph, for short paragraph for conclusion. In conclusion, this retrospective study reveals that image-guided percutaneous cryoablation is a safe and effective method for local control, and the major adverse like this, and also 24%. I added some part. Regarding the Dr. Alfaro mentioned, references are very wrong. That's why I asked him to add this one and check the reference again. For example, this is a correct one for JVR, and this one. And I'd like to show you what I did for the figures, okay? And then we can have time for discussion. But Manuel, I cannot share.
There you go, Dr. Song.
Okay. Regarding the figure, okay, everyone can understand that this is an ice ball, but it's better to use some arrows or arrowheads. This is, for example, the low density ice ball, and also this is a head of specific indications, tumor. And also, yeah, it's important to describe the abbreviation here. Probably it's better not to use abbreviation if it is possible, but as long as you use the abbreviation, you have to note there is a abbreviation or something like that. This one also, also this one. And then finally, I'd like to share the table. Here you can see I added 7 new references for him to compare. And also I asked him to delete the table 1. And also table 2 is okay. Table 3, there is a minor one. So this is the one I did for the first author, any comment or questions regarding this manuscript?
I wanted to show my about the figure. I just
Sure, sure. Okay, please.
I would have made one difference, one change, because you see the difference here. This last one was like that, and I was like, well, why do you have two?
Yeah,
one orientation? Why don't you just change it like that? Now it
yeah, good idea.
the orientation
Sure, sure.
of the other one. So I didn't
Yeah,
know.
that's good idea. Sure, I agree with you.
Yeah, I think it's important to keep that. Other than that, yeah, I think the first table that you mentioned was very, because it talked about all the malignancies. So yeah, maybe it's okay to exclude. And other than that, yeah, I didn't have any other.
Dr. Alfaro, any questions or comment?
No, let me see the table. I saw them before, but let me see. But what I didn't find, maybe I didn't put enough attention, is the the difference of the results. I mean, the efficacy compared with the size of the.
Yeah, a little bit different. Sure.
So I couldn't find it like clearly somewhere. I think that was one of the main points.
Yeah, I corrected the table too. Yeah, you are right. And Dr. Gamboa, any comment or question?
No, just a little comment about the abbreviations. There are many papers that they write the abbreviation previously, before the introduction and the purpose. It is written in the first paragraph, and then they start writing. So you have to write the abbreviations just one time.
Sure, sure. In the text, but regarding the table and the figure, you have to note. There should be note.
Okay.
Okay. And then today I'm going to send my revision to all the meeting attendees, or just to Dr. Gamboa or Dr. Alfaro or Dr. Celedon, 3 people. Dr. Celedon,
I think if you
want
send it to the 3 of us, that would be okay.
Okay, it's better, right?
Yes.
So okay, I will do that just after this meeting.
Okay.
And thank you very much. And then Dr. Gamboa, you can send your manuscript to Dr. Celedon at least 2 weeks before the meeting, right?
I will try, yes.
Because the earlier the better. Also, I'll review it, and then I am becoming busier and busier because of many lectures here and there, including Africa and the United States through Zoom. So Zoom is very effective, but sometimes it's not good because they asked me so many lectures through Zoom. That's why please.
It's hard to
send. Okay.
Well, okay, so then I think we're finished. I think that, yeah, well, actually it was perfect, 1 hour. So, muchas gracias a todos por unirse. Gracias, Dr. Alfaro. Gracias, Sofía, como siempre. El Dr. Lopera had to leave, but other than that, muchas gracias a todos. Thank you, Dr. Song, and we'll see each other next week. Okay, gracias.
Okay.
Bye-bye.
See you next week. Thank you very much.
Muchas gracias.
Gracias, buenas noches.